Dr. Omkar Swami on behalf of Emcure Pharmaceuticals Limited. Welcome you all in a most engaging scientific program of India. That's no thrombosis.
Recording in progress.
Though sir is a coronary interventionalist at heart, he is equally adept at peripheral arteries interventions like leg, carotid, and aorta. Sir had participated in many groundbreaking trials. Thank you very much, sir, being a part of this program, being a course director of this program. And over last 23 modules, we have learned so many of things under your directorship, sir. Thank you. Thank you very much. I also welcome our course moderator, Dr. Jabir Abdullah sir. Sir is currently working as a senior consultant and director of clinical research of cardiology at Lisi Hospital.
Dr. Omkar, you've been muted.
Yeah, I unmute, sir. Now, I welcome our course director, Dr. Jabir Abdul sir. Sir is currently working as a senior consultant and director of clinical research at Lisi Hospital, Cochin. Sir has more than 2 decades of working experience in cardiology, and sir has been recognized as a faculty for many national and international conferences. Sir has been an expert in managing complex heart diseases, and sir's area of interest is coronary intervention and heart failure. I also welcome our course moderator, Dr. A. Srinivas Kumar sir. Sir is currently working as a senior consultant cardiologist and director of cardiology and clinical research at Apollo Hospital, Hyderabad. Sir has been a chairman of a FACTS Professional Services and a founder editor of National Medical Journal of Postgraduate Medical Clinics of Usmania. Sir has been a founder director for the Advances in Cardiovascular Solutions of India, TCT India, South Asia Conference. Sir has a special interest in TAVR, TAVI, ASD, VSD, and IVOS. Sir has been a president for Cardiology Society of India for AP chapter. Sir has been a principal and co-investigator for more than 10 clinical trials. So today we will be having 3 interesting presentations. Our first presenter would be Dr. Amit Sharma, sir. He is currently interventional cardiologist at Holy Spirit Heart Center at Mumbai, and sir will be presenting on coronary thrombus. So we have second presenter, Dr. Anuj Sarda, interventional cardiologist at Intima Heart Care Clinic, Nagpur. Sir will be presenting on massive thrombus in RC in innovative melting technique. Our third presentation will be Dr. Parag Rahatekar. He is working in Nagpur at Anika Heart Care Center, and he will be presenting post-COVID myocarditis, an interesting case. With this short note, let's go back to our course director for the further deliberation of this program. Over to you, sir.
Thank you, Dr. Omkar, and good evening, everybody. Welcome to this forum again. And this is a forum where I think all of us are trying to put in all our thought processes, discussing, learning from each other. And I hope everybody feels good about it, the way the program is going. So, Omkar, where do we go first? Amit Sharma?
Yes, sir. Yes, sir.
Okay. Dr. Amit, can we request you to start your presentation?
Am I audible, sir? Am I audible?
Yes.
Okay. First of all, a very good evening to all of you, sir. It's indeed a privilege to be here on the same podium with all you fellows out there, Dr. Kutty, Dr. Srinivas Kumar, and Dr. Hiremat. I wish you all the best for tomorrow, sir. We are all eagerly awaiting this much-awaited conference. Let me begin, sir. This case is not exotic as sir would, want it in terms of intervention or so, but it's a case that's very close to me because this was something which, baffled me too. I'm just going to share my screen. Yeah, is the slides are visible?
Yes.
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 Okay, thanks. So I begin my case. So this was the 35-year-old male. This was around 3 years back. I'm talking of 2018. This was a 35-year-old male, absolutely no comorbidities, normal EGFR. He got admitted in the late evening with acute inferior wall MI, and it was 2 hours duration since symptom onset. He came to the ER and he had a VT for which he was cardioverted, and he was shifted promptly to the CCU. In the CCU, he had a complete heart block at that time, for which atropine was given. Quick bedside echo was done. The ejection fraction was normal. There was no regional wall. There was a definite hint of RV myocardial infarction. The systolic pressure was around 90. Fluids and inotropes were started. The due deliberation was done with the relatives, and subsequently the patient was wheeled into the cath lab at 9 p.m. And this was the ECG, which is showing the acute inferior wall, which is quite evident on this. And this was a right-sided lead where you can see the ST elevation in V4R and V5R, which is evident. And this was the angiogram. This was the left side, which was done and which was normal. And this was the right coronary angiogram. And that shows a very large layered thrombus, which you can see in the entire right coronary artery, right from the origin. And so then began our tirade where I tried to do a thrombosuction and, relieve that thrombus burden, which was quite significant. I used intracoronary vasodilators, adenosine. I used almost every possible thing there.
Can your movies run? Dr. Amit,
sorry, yes.
Can your movies run? They're not running.
Yes, here it is.
And the next one on the side also.
This was what 1 a.m. After around 4 hours of this was all that I could manage in that time. And it was a very resistant thrombus. As we know, young patient presenting with an inferior wall MI with this. And the moment I would thromboaspirate, I would see that the distal circulation has cleared, but there would be thrombus lurking in the proximal segment. Again, go about and trying to do thrombosuction, proximal segment, the distal would get clogged. So this kept on happening despite giving intracoronary vasodilators, etc. And this was after about 3 to 4 hours, I finally got this result. And I thought that maybe this is enough for the day, though I was not happy, of course, knowing that the PLV is a very big vessel and it's still occluded. So I have not yet given a TINI flow. But at that particular time, as he seemed to have stabilized, things were a little bit better. I said, let me wait and reassess. Maybe it's all thrombus, and I would have just maybe put this patient on a GP2B38 drip for 24 to 48 hours. But of course, I had already gone on the front foot and I had done this. So there you can see this was the result that I got on that day. So after this, the patient was shifted to the CCU. And this is the notes you can see at 1 a.m. Again, I did a bedside echo to see whether any damage done. By this time, the inferior wall was definitely hypokinetic, and the ejection fraction was around 50%. It was not bad at all. There was a RVMI, as was evident. The patient was put on inotropes, and he was started on a tirofiban drip, and he was shifted to the CCU for the next 24 hours. He continued to have chest pain for 70 hours post-procedure. I attributed it to the probable DC shock that he got because there were no fresh ECG changes and the ECGs remained quite stable. He was on enoxaparin 0.6 milligram 12 hourly and of course our dual antiplatelet therapy. He was on aspirin and clopidogrel. Since he was loaded with that, I did not change it to any ticagrelor at that time. And I planned a check shoot after 72 hours. Now, this is after 72 hours. This was the angiography that was done. Now, essentially the same. The patient was virtually asymptomatic and he was absolutely fine. And he said that I'm totally okay. So then at this stage, discussed with the relatives, there were 2-3 things in my mind. One was that possibly the artery is occluded. It's been more than 3 days. Now, should I really go after, chase this, revascularize and open that huge PLV? So that was one thing on my mind. But again, leaving him a young person with...
Can you run
Yes, sir. Yeah, I'm running it, sir, for you.
That proximal RCA stented, doctor, it looks like there is a stent or a staining of the layer.
It's a stent, sir. It's a stent. I put in a 40/38 ceronic stent at that position.
40/38.
Yes, sir.
Okay.
So with this, he was okay, and now we thought, should we, what to do? I mean, I really didn't know. He was asymptomatic. Now, going by your hypothesis that we had from all the earlier trials, we know that on the third day to intervene is sometimes, not that great results in terms of clinical outcomes. But here we have a 35-year-old fellow, and with giving such a result, it sort of broke my heart. So I discussed with the family that let's go ahead and do a thrombosuction to the PLV and probably a bifurcation, because the ostial PDA also had a lesion, but the family had financial issues. So at that time, he didn't want to go. So I started him on a hunch on rivaroxaban, 5 milligram twice daily. I downsized the antiplatelets to aspirin 75 and clopidogrel 75, and we discharged him. And he came for follow-up. He was very regular, and I stopped the rivaroxaban after 3 months. I continued the DAPT. The LDL at 3 months was 52. Now, after 5 months, in December 2018, he comes back with similar chest pain. And ECG absolutely fine, no fresh changes, and the echo absolutely normal. So at this time, I feared the worst, thinking that maybe is it just that, I left it there and probably there has been a new lesion or so. I took for a and this was the angiography which was done after 6 months. So here you can see that the PLV has absolutely nicely recanalized, and probably it was just all the thrombus there which was causing it an issue. I'll play this again. There is some proximal stent in glucose visible. So this was house, and I'm pleasantly surprised with this result. And this was 3 years back, before the Compass data came in, which is now. The dual pathway inhibition concept, it sounds really very much plausible that there is a plaque erosion. Your antiplatelets will work on that, plus the coagulation cascade, which will be taken care of by your oral anticoagulants. Now, which NOAC was that time in my mind, because the REDEEM and the Appraise had just come in, and they were not very positive in terms of dabigatran and apixaban. So at that point, the only trial I relied on was the Atlas ACS, which had come in around that time. And there, the 2 doses that were used were 2.5 and 5. Now, since my patient was young and there was no bleeding risk as such, so I started him on 5 milligram twice a day of this drug on 3 months. And I really don't know whether that Compass dose of 2.5 milligram twice a day would have worked, but I guess it would have. But the thrombus load was too high, and I subsequently discharged him. He comes on follow-up. He's virtually asymptomatic, and this is all my case. So I would want, for discussion, whether was it the apt thing to do, or would anybody, sir, would have, Dr. Hiremat sir or Dr. Srinivas, whether you would have done anything different from this?
So, Dr. Amit, excellent case. I mean, a lot of thought processes. Let me ask Dr. Srinivas, would you have gone for the PLV on the first day itself? I mean, here, what opened PLV, why there is no thrombus, and there is an excellent flow in PLV after 3 days. And I think you would probably give it to the intracoronary GP blockers that you use during the procedure. And you didn't use any Elexim or anything during the procedure. First day,
I did use, sir. Intracoronary tenecteplase I did use in aliquots of 1 micromilligram. I did give it in multiple, almost 5 or 6 times. because it was a very stubborn thrombus. It just would not budge. And even if it did, it just would just come back magically. And so I had to leave that PLV occluded after 4 hours of all this therapy that we did. And I thought at this stage, at least if he's asymptomatic, the pressures have come up, the VT has not recurred. He was put on a temporary pacemaker. So I was very unhappy. I add that it's always
we really appreciate that since the patient was very young, you had the intensity and you brought him back to cath lab, and then you could see a well-flowing PLV. So I think very commendable job. Suppose you had found that PLV is not flowing when you brought him back the second time on day 3, right?
Sir, it was occluded. Even on day 3, the PLV had the similar type of picture. It was totally occluded. And the PDA ostium had a ostium plaque was there, sir. It was thrombus was there at that time too. And that's when I wanted to do, for the third time, I wanted to do a thrombosuction again and go ahead with a bifurcation PCI was my plan actually, to which the patient did not agree because of the financial situation that he was in. And at that particular time, I had to put him on this dual pathway therapy and send him home, but with a close follow-up kind of thing. But the second time when I did the check shoot on day 3, it was essentially the same. The thrombus had just occluded that huge PLV, sir.
No. We see a nice flowing PLV in the end.
Correct, sir. Yes.
So that was
after 3 months or something.
After that,
he came back next.
After 3 months, he came back with chest pain. After 3 months, so then I had to reshoot him again, and that's when I saw the flowing PLV. So that put me on this thing that.
So your usage of rivaroxaban, it's the one which you would credit this opening of PLV, correct? I mean.
Yes, sir. I presume because yes, sir.
We give antiplatelets to anybody who is stented, and we don't see artery open like this. You didn't work on the PLV, right? I mean, or you did aspiration and everything.
No, I didn't, sir. No, I didn't do it, sir. In fact, that's what even my technicians were telling me, that you're leaving an artery like this, and I was also quite unhappy with that. And we tried to tell them that we will try and amend the cost or something, but they were just blanket. He's asymptomatic. We don't want to do anything further. I think it's best that we put him on medical therapy. He's totally fine. And that's when I called him after 5 months. I did not call him for the procedure. He came with chest pain, and we got the angiogram done in view of that similar chest pain that he had 5 months back. That kind of situation. Sir, with due respect, we see a lot of coronary thrombi and everything. And given as the interventional cardiologists that we are, we usually end up chasing all these thrombi and everything. And we do manage TIMI3 flow, even though if it is maybe slightly more sluggish, but at least we ensure that we leave the patient with a TIMI3 flow at least. But a few of my cases which I have seen, sir, this is one of the cases only. I have at least 2 or 3 more cases where the degree of thrombi has been more. I'm talking, this is all prior to COMPASS data, sir. And we have left them on rivaroxaban, and I have got a result like this. I cannot generalize it, of course, sir. But
COMPASS was not angiography directed study. The COMPASS, the dose was 2.5 twice.
2.5.
And it was started at the end of 1 year. It was not.
It was chronic CAD. Chronic CAD.
It was not an acute initiation of rivaroxaban. So it was a late COMPASS. So in this case, you use 5 milligram twice a day, which is a double dose of COMPASS, isn't it?
Correct, sir. Yes, sir. Yes.
This probably worked. I think the double dose probably worked. I mean, I don't know whether we should generalize and start saying that in an acute situation, you should give a bigger dose. But then to dissolve a thrombus, like if this was to be a pulmonary embolism, you would give a bigger dose.
Correct. Yes.
I would probably feel that giving a bigger dose really helped this particular patient. Dr. Srinivas, you want to have any comments on this?
Yeah. I think there's some series of learning points which were very well highlighted. And first, what you presented is patient came very early to hospital. For patients who come within 1-2 hours, there's a high chance of sudden patients getting into the ventricular fibrillation, arrest, and DC shocks. We should be geared up to be ready. That in ER, you people did a good job. That's how patient recovered. Otherwise, many of the times the attendants say the patient came walking and suddenly something happened. So first 1-2 hours is very critical. Then again, he went into CHB and you documented RVMA also quite well. That is quite appreciable. And then immediately took the patient to lab. Struggled for 4 hours. That's what sir was telling.
If you have diagnosed an RVMI and you want to take the patient to cath lab, do you, as you are taking, say 10 minutes will go, 15 minutes will go, do you take some extra steps to handle the RVMI?
Fluids, he was telling extra amount.
Sir, the only thing, fluids, inotropes, judicious use and use of fluids, inotropes, and what I did, sir, is the pacing wire is what I was worried about. But it's a RVMI, so immediately as soon as I went there, I kept it in the right atrium, sir, the pacemaker. I did not dip it down totally. By the time his rhythm had recovered, so I just had to, if any eventuality had to happen, I just had to push the wire through the valve. That's it. But I kept it in the right atrium through the study. We had returned to sinus rhythm by then, once the thrombus and the flow had started a little bit. But the pain did not subside at all. And in fact, it continued for 3 days. And that got me a little worried. Leaving the PLV occluded like this with a chest pain, which was going on, happening. I was all those 72 hours were on literal tenterhooks,
But, it doesn't push you on day 3 to open a occluded vessel.
Yeah.
I mean, by your point that patient had pain on day 3 also. But whether it was a true angina and your opening up of PLV is going to be of great help. But the PLV pictures are just stunning. I mean, it looks a very, very clean artery.
But many times, no, sir, in the acute stages, we do find large amounts of thrombus. Previously, we were putting them on warfarin plus small dose clopidogrel, things like that. Now we are putting a NOACs. That's a good thing because no monitoring, better efficacy. But definitely in such things, I think we should use full dose, like what you did, 5 milligrams BD, not 2.5. You are expressing doubt whether 2.5 milligrams BD would have been sufficient. I don't think so because
the other thing is holding back of aspirin. I think for first 1 month, I would give all 3.
Yeah, I mean, he gave, I think, 75, and 5 BDs. All 3.
Yes.
Yeah.
First 1 month, definitely give 2 antiplatelets and whatever dose of rivaroxaban. And then after 1 month, you can take off aspirin. I don't know whether there is science behind this, but there are a lot of studies in which they have stopped aspirin at the end of 1 month. Any hints you want to give us to diagnose RV infarct on echo?
No, sir. As I told you, sir, it was quite evident the way he presented only that this thing. The ECG was a giveaway totally. There was ST elevation, V4R, V5R, and other leads which we saw. His pressures were 80 systolic.
It's more on
correct.
More on ECG, you're talking of RV infarct.
And the echo, sir. We did see the free wall hypokinesis, but the inferior wall per se on the initial echo did not look bad to me at all, sir. And because the focus was on immediately moving the patient to the cath lab, so it was a screening echo, and the RV was quite dysfunctional, but the LV ejection fraction was preserved. It was only after I shifted the patient, I noticed that the inferior wall had now shown up after the procedure.
Yeah, good, definitely. Sure.
I think one more point, sir.
Any hints on the RV infarct on echo?
Yeah, that's what he was telling. No, RV, when you see the RV free wall contracted, it will be less, and even sometimes if it is extending further, the apex movement also could be seen, but free wall is generally well appreciable. When you put it to M mode also, the movement will be significantly less in the various views. Omkar, actually, I was suggesting, sir, for them to collect this intracoronary tenecteplase things. It happened in one of the other presentations also. Here also, doctor used intracoronary tenecteplase aliquots, he said. Like a lot of times, it tends to go not reported, but we can keep collecting and demonstrate that one, it is safety, and then it is efficacy. I think it worked because finally the artery could have been opened with multiple cocktail regimes anyway, I would say. But most important is to get the pressure back. If pressure is normal, generally thrombus gets washed out. If pressure doesn't recover, then whatever you are doing still again, it tends to get accumulated. I think
The other thing, Dr. Srinivas, continuing of clopidogrel. I mean, why must you continue? I mean, we clearly know that both ticagrelor and prasugrel are going to be better drugs. So even if he was loaded, I would ignore the clopidogrel and give him ticagrelor in standard dose. So load him as you go on, and this is going to be clearly better for first few weeks or first few months.
Novak, ticagrelor, and aspirin, you are saying, sir?
Yes.
Yeah. Because the benefit would be more here, obviously, and patient is young, less chance of bleeding, you could still do it. But only thing is, elderly patients like thin, frail, diabetic patients are likely to bleed. Sometimes we tend to avoid these newer ones along with Novak. But in young patient, 35 years, I think benefit would be more by giving ticagrelor along with this. And that's how finally patient improved and went to home. That is a proof for what you did is right. I think many of the times we have seen the thrombosis getting dissolved on follow-up, entire artery will be open. We have seen such cases many of the times.
Yes. I agree with you.
I mean, Dr. Amit, all 100% mark in your favor because...
Thank you, sir. Thank you.
Because you have an open artery, you have preserved ventricular function. And so, I mean, all steps went in your favor, but they may not always go in your favor. So I would have probably,
I agree, sir. I agree.
Yeah, I would have probably on day one when you are doing the procedures, I would have chased that PLV branch.
He struggled for 4 hours, he said, sir. What else did you do? 4 hours he tried in cath lab.
Yes. Kept moving, sir, all the way across the artery, all the way across. I wish I could show you the entire shoot, because it was in such a flurry and so much this. And remember, sir, this is off-label indication in 2018. I mean, at that time, the only thing I knew was that it's Atlas ACS was the only study that had come in ACS. In fact, Compass came much later. So this was the only thing that I was left to, use.
But sir is talking acute stage in the cath lab.
Acute stage.
Done thrombosuction and chase that PLV. That's what sir.
I agree, sir. But after 4 hours at 1 a.m., I had to call it a day.
I think you must have done thrombosuctions, no? Even the distal RCL. PLV also you must have done thrombosuction.
Yes.
Okay.
Yes, sir. Across.
So what do we focus on when we have so much thrombus-laden artery? Aspiration, I feel, is top on the list. I think you must aspirate. There are studies which show that aspiration doesn't work, but I think all of us who are hardcore interventionists have seen so many benefits of aspiration of the vessel. The other thing is giving the thrombolytics. Like in this case, you use tenecteplase. But you also used intracoronary GP blockers?
No. I did not use GP. I used it systemically. Intravenous tirofiban was given, sir, at that time. But intracoronary, I used only thrombolysis, sir. Your tenecteplase.
But I would probably feel that intracoronary small dose of GP blocker very effective. So I would probably give that. If that fails, then we switch to Elexim and tenecteplase. And this patient was discharged on clopidogrel, or you switched him to ticagrelor?
Rivaroxaban, sir, for 3 months. At 3 months, I stopped the Rivaroxaban since he was back totally normal. Though in my heart, I knew I always wanted to do a check shoot and see, but because he had financial issue, so he came back at 5 months on his own. So. But I agree. Of course, the only thing, lack of data, sir, with NOAC with a Tika is a little bit this thing. That's the only thing. But of course, young patient, no bleeding risk, I would definitely think it would be high in the cards.
I mean, clearly, I don't know whether Dr. Srinivas would agree with this, but this is not a case which is defined in textbooks. I think everybody sees what is happening. 4 hours, middle of the night, you struggle.
Correct.
And you are allowed everything under the sun to use. I would feel that way. And finally, what you achieved for this young man is outstanding. He would carry his blessing all his life. And I'm sure we all feel very happy
Yes.
to have a patient like this going so well. So congratulations.
Thank you, sir.
Dr.
Thank you.
Jabir is joined us or he's not joined us today?
Sir,
Other two, Dr. Parag and Dr. Anuj, you have to say anything, you can comment on this.
Sir, it's a really a nicely done case. My case is more or less about the same concept of the thrombus. With the same, I was also stuck up with the thrombus.
Okay, we'll see your case.
We'll
You're
see
showing
your
your case, right?
Yeah, sir.
All right. So any other comments? So Dr. Amit, as I understand, you used tenecteplase right in the beginning after aspiration.
No, once it was only in desperation, sir. After I had used intracoronary vasopressor.
And then it may be desperate, non-desperate. That's not an issue. But
Correct, sir.
what I'm asking you, did you use GP blockers first or you use tenecteplase first?
So systemically, I started him on GP2B3A. On seeing the thrombus load, initially itself, I had given a bolus, intravenous, sir. And then after that, once I started the procedure and it went on like this, and the thrombus being pushed over here, there, everywhere, then came the intracoronary thrombolysis, sir.
So did you give it through the right coronary catheter or you give it intralesional? That is another thing which you want to ask.
So intralesional, sir. Intralesional, because I usually use the thrombuster catheter, sir, and I deliver it with that, sir, once I have cleared the catheter.
So I think this is a very important thing that when flow is not established, we try to give it intracoronary, but intralesional is probably much better than giving intracoronary.
Okay.
So I think this was a very challenging case. It tested Dr. Amit extensively. I mean, 4 hours at night, and then so much of thought must have gone in for next 2 days as to how to handle this case. But very well done. So you are going to give him long-term rivaroxaban, or you stop it at the end of 6 months?
3 months.
So now what I've done, sir, since he's come for follow-up, now I've gone back to the compass dose for him, sir. So now he's on 2.5 milligram twice a day and on aspirin, sir. 75. Now on follow-up that he has come, because I believe for him dual pathway will work. He's likely to have a thrombotic risk, which is going to be high in the future, considering the event that he's had at 35 years without any risk factors. So I've kept him on a compass dose now, sir, at follow-up.
But I would feel compass was not a thrombotic arteries.
Yes, sir. No, this is 3 years, sir. This is 3 years now. This was in 2018. So now he's been put on compass in last 6 months or 8 months that he came to me for follow-up, sir.
Okay. Well, very well. I think all of us learned so many important points from this case, and congratulations and thank you from all of us.
Thank you, sir.
For
Thank you.
An exciting case.
It was great hearing your experience, sir. Thank you, Dr. Srinivas Kumar, sir.
Thank you.
All right. Who is presenting the second, Dr. Omkar?
Dr. Anuj Sarda would be presenting second.
Yeah, Dr. Anuj, can we have your case?
So Dr. Jabir sir is in cath lab. I checked it with him, so he is stuck with the emergency and currently in cath lab. Dr. Anuj, you need to unmute yourself.
So Dr. Jabir is likely to join us or busy in the lab?
He's in lab, sir. He's in lab, stuck up with the emergency. Maybe it's completed, he may come.
The slides are there?
Yes, yes. We can hear you. We can see your slides.
So Dr. Anuj, I don't know, you are in Nagpur or you are in...
Sir, from Nagpur, sir. From Nagpur, sir.
From Nagpur, okay.
Good evening, sir. It's a privilege to put forward a case of thrombus. It's a more or less a same case, but this time this is a massive thrombus in my case. And I think this is a great platform from Know Your Thrombus. Particularly, there are the two nightmares inside the cath lab. One is the thrombus and second is the calcification.
Perforation also.
Perforation is definitely most of the time what we face is the thrombus and the calcium. So my case profile is he's a young gentleman, 34-year-old male, presented to me in a state of acute inferior wall MI, reached within window period. And vitally stable, regional wall motion abnormality in inferior territory, basal inferior hypokinesia, no MR, ejection fraction is okay, it's 45%. And as far as the risk factor evaluation, no non-diabetic, non-hypertensive, non-tobacco chewer, and no significant family history of CAD. And particularly in this COVID era, there is a no history of COVID exposure or any vaccination prior to it. As the relatives, they are willing for primary PCI. We have taken this patient for the PCI, and these are the all left side shoot. The coronaries, they look pretty young to me, and they are absolutely normal on the left side. But on the right side, the picture is quite difficult for me, and there is a massive chunk of the thrombus straight from the proximal part, and it engaged the mid and the distal part of the RCA, and it's a more or less a snail sort of appearance inside the coronaries. So as we have already committed this patient for the primary angioplasty, so I thought it's better to start with a conventional thrombus aspiration catheter. This is a 6F catheter, and we are doing by radial. So we have tried multiple run of the thrombus aspiration catheter. There are the multiple run we have taken, but there was no significant improvement as far as the thrombus is concerned. The flow, we are not able to establish the flow inside the vessel. So in this point, I thought it better to put some thrombolytic therapy to that. That's why I have used intracoronary thrombolysis, and directly I have put inside the artery through the catheter, not the intralesional by means of thrombus aspiration catheter. And we have put a 5 milligram of retiplase, and we have waited for 5 to 10 minutes for it. But in spite of that, there was no significant improvement. So I thought, as we have already given a tirofiban as well as the thrombolytic therapy, so it's again try one more time with a conventional thrombus aspiration catheter. So we have tried with the thrombus aspiration catheter. One more time we have tried with this, but without much significant improvement. So now more or less we have run out of the option. Thrombus aspiration we have tried, intracoronary thrombolysis we have tried but failed, and intracoronary tirofiban and all mixture of Nicor and NTG and nitroprusside we have given, but it's failed. So what next? So I thought we should try a guide extension catheter in this case particularly, because in the first shoot I realized the anatomy. It's really a good size vessel. It's around 4 mm vessel size, and the straight anatomy. So I thought we should use a thrombus guide extension catheter as a thrombus aspiration catheter. So the reason is the internal diameter of guide extension catheter is better in comparison to thrombus aspiration catheter. So very carefully and gently, I have put a thrombus aspiration catheter and try to aspirate with thrombus aspiration catheter. The only thing, the manipulation is very important as far as the guide extension catheter is concerned. We usually use guide extension catheter for the other purpose for the support, but this time I have used as a guide as a thrombus aspiration catheter. So this is after the first 1 or 2 run of the thrombus aspiration catheter. There was a significant improvement inside the vessel as far as the thrombus is concerned, but still the flow is not that much of great. And here again the same problem what Dr. Sharma has faced. There is a significant chunk of the thrombus still inside the PLV. So this is the basic concept of the thrombus aspiration catheter. We all know the internal diameter is around 1.4 to 1.2. Particularly in this case, I have used the Guidezilla, so it's 1.4, the internal diameter, in comparison to the thrombus aspiration catheter where the internal diameter is around 1. So this is what this turned out beneficial for us. And I have taken another second or third run of the thrombus aspiration catheter and got a comparatively better result. But still the PLV is occluded. So I thought it's better to address the PLV there and then only. So this time we have put a conventional thrombus aspiration catheter, but unfortunately that got kinked, and there is a significant loop is formed inside the vessel at the mid RCA level. But particularly the picture on the right side, where you can find there is a loop inside the RCA, and this loop is turned out, you can say, is a blessings in disguise. It's like solitaire catheter we usually use in neurointervention. So I thought it's a good time to trap the thrombus. So at this point of time, we trapped it, and we gently put the guide inside the RCA. So there is a chances of embolization should be less. So we got a satisfactory result after this. Even though PLV is still not flowing, it's 100% thrombotic occluded. And this much of chunk of the thrombus we have removed from a single artery. For me, this is really a first time I have removed this much of thrombus. Here you can see there are a large chunk of the thrombus from the one case, particularly from the coronary. So as I don't have an imaging with me, so I thought it's better to, particularly this is a culprit to me. So I think it's better to fix the lesion. So we have stented with 4 into 15 and 16 atmospheric pressure, and these are the final results. So as far as the PLV is concerned, we have not chased the PLV further, and we close our case at this point of time. So in the nutshell, the coronary thrombus is always a challenging case scenario. And even though the conventional thrombus aspiration catheter is downgraded in recommendation, but sometimes it's the essentiality. And the thrombus aspiration catheter is one of the innovative way to go ahead. But the most important thing as far as the guide extension catheter as a thrombus aspiration catheter device, you have to very careful and meticulous. And most important thing is you have to know the anatomy of the artery. That is the essentiality, because otherwise the chances of dissection are very high. And one more thing, there is always a chances of embolic episode, particularly down the line, is high when you are using such a bulky device. So these are 2 or 3 important points I would like to highlight as far as the guide extension catheter use is concerned as a thrombus aspiration catheter. Thank you. Thanks a lot, sir.
Oh, Dr. Anuj, that was really exciting, the way you struggled, the way your thought process went from one to other to the next and so on. Just to be in line with what you showed us, I had a vein graft once, and the vein graft, acute infarct, fresh story, and we were unable to establish flow. So we put a whole guide catheter, not a guide extension catheter, but a whole guide catheter supported by a balloon at the tip. So first wire went in, then the balloon went in, and balloon was kept inflated, so it was sort of anchoring. And then on that we slipped in a catheter. And after almost 2 hours of trying everything else, this was the only thing which worked. So I think getting thrombus out the way you did is probably ultimate, and nothing else would work like this. But guide extension catheter I had never thought of guide extension catheter to aspirate. Let's ask Dr. Srinivas whether he had thought of anything like this earlier.
Like we, as you said, sir, we sucked many times with the guides directly, and export catheter is used, but many times it gets blocked. So get it out and clean it, again take it inside, and then many of the times we keep trying that. Sometimes 6 French doesn't work, changing to 7 French also with the better lumen.
Exactly. That was another thing. You were with radial, right?
Yes, sir.
Anuj? Yeah. So I think you people are not used to switching from 6 to 7. But what Dr. Srinivas is saying is the bigger bore aspiration catheter would have worked.
And the 7 French nowadays with radial and other things being available can even put no sheath, sheathless, directly 7 French guide sometimes could work. Because in acute stage, you must not have thought of. But many of the time changing to bigger French also suck the thrombus in a better way. Guideline is another way of doing it, but you should be important. You should be careful, as you mentioned, not to dissect the arteries while going too deep. But as sir mentioned, we did try directly taking the guides inside. And only precaution again you would say is while taking it inside, you should be careful not to dissect the arteries. That's what sir was telling. Already pushed the balloon inside and anchored it, then it goes in. So the balloon, whenever it is there, balloon is there. Even if you do manipulations over the balloon, it will be safer for the guide going in also. But otherwise, you should be careful. So guideliner is another method to aspirate. But many of the times, guideliner lumens also could get blocked because they may not have also that great lumens. Like guide catheters have bigger lumen, obviously. But that is another way what you thought is innovative and it worked. And by whatever means you try to get the thrombus out, it's always good. But exactly similar cases you picked, Omkar. The distal PLV is occluded even here. The result is also same. Not only the initial
Dr. Srinivas, I wanted to ask you one question.
Sir.
Like in these kind of cases, having aspirated and then you have a decent flow and then you decide to put in a stent. I want to ask you two questions in one go. Whether you would avoid doing a balloon dilatation, that is one. That means whether you would prefer a direct stenting. And question number two, the stent diameter, whether you would probably like to oversize a bit and under deploy. Like
Yes.
In a 3-5 vessel, take a 4-0 stent and deploy low pressure, something like 6 or 8 and come out. Don't stretch it. So what are your thoughts on these?
Yes, sir. Whenever you have a lot thrombus burden, what sir was mentioning is you can avoid going to too much high pressures because it squeezes and causes slow flow. In that case, probably taking bigger size stent, but I would always prefer at least to go to nominal, sir, not just 6 or 8 of the stent. Nowadays, with Abbott type, the Zine stent, nominal is 10 itself. You can select a stent which has a less atmospheres as nominal, but unless we go to nominal, we are not slightly comfortable leaving stents only with 6 or 8.
No, we are oversizing it as a.
Yeah, but still, sir, unless you go to at least nominal atmospheres, I'm not too sure how the stents.
No, I'm not talking of deploying at 4 and 2.
Yeah,
I'm talking of deploying around 8 or
8. That sort of thing. Agreed.
Not take it to 20 and 30.
Yeah, 20 definitely not. Just nominal atmospheres pressure. And always when thrombus load is more, also we try to avoid too much balloon dilatation because that could also precipitate slow flow. But initially you must be worried that there's no flow happening at all. Directly to put a stent in that worry, we keep doing all this. But thrombosuction and probably if you can get away without doing balloon dilatations could be okay. But many of the times you must have also done balloon dilatations, I would agree. Because unless you get some good flow where to end the stent, sometimes you feel it challenging. That's how I think you also balloon dilate. But generally, by and large, thrombosuction, if the distal vessel where it is there is seen well. Many of the times giving intracoronary nitroglycerin along with other things also helps because vessel gets into spasm goes and a lot of flow happens and dilates. And that also helps to wash out the thrombus. Only thing is pressures need to be maintained. Pressure is low also, then it's difficult. But otherwise, pressure is maintained well. That itself is a big factor, no, sir. If blood pressure is maintained well, many of the times thrombus automatically gets flushed out and results improve. So maintaining good pressure is important.
The intralesional use of whatever, GP blocker or the thrombolytics, I think that is much better. Like in both these cases,
Yes.
I think you give through a guide catheter, it will not be able to resolve much of thrombus. But if you give it deep inside, like put whatever aspiration catheter you want to put, give some lytics there, and then you come back. I mean, as you are injecting the lytics, you slowly withdraw the guide catheter, so the entire length of the thrombus, it gets these intralesional lytics. I think that is the best way. So, what kind of dose, Dr. Anuj, you would consider giving intracoronary if you are using Elaxin?
Sir, in this case, I have used the 5 milligram of Retiplase. What the review of literature revealed, sir, it has to be the 1/3 or 1/4 of the systemic dose, sir. Whatever. If you are using Tenecteplase, then 10 milligram of Tenecteplase. And
do you make a difference between right and left coronaries, the dose?
No, sir, it's the same. It's a 5 it's a 1/3 or 1/4 for the coronary. It's a coronary dose, intracoronary dose of any thrombolytic therapy.
Obviously, there's no definite recommendation, but it's all experiences.
It's anecdotes.
Collect the data and come out with a sort of recommendation, which would be the ideal. That's what I was trying to say.
I would probably feel that don't spend too much time whenever you're dealing with used thrombus. You establish flow, give whatever lytics or GP blocker you want to give, deploy the stent and quickly come out. I think that is how you preserve the flow much better than trying to play around.
Yes. And the more longer you stay inside, the more problems happen. Yes. Procedure times is one thing, where if it is longer, more than an hour, generally it tends to get into trouble also. We need to check our ACTs, heparins, all that also sometimes.
Yeah, Dr. Srinivas, you didn't answer the stent size.
Yes, sir. Stent size, I said, no, sir, we agreed with your point that you take little oversized stent and don't go to high pressure. Just to, rather than ending slightly less, I would just end up with nominal atmospheres. And we prefer stents which have lesser atmospheric pressures as nominal compared to those stents which have 12 and 14 as nominal. But that point is to be considered, and generally try to take, initially in the vein grafts also we used to follow the same, no, sir, because we take slightly bigger stent and don't stretch it too much to avoid the flow. That is generally a thing which is followed. And regarding the balloon dilatation also, I said we will not squeeze it unless it is absolutely essential. We generally try to do thrombosuction and then go give the nitroglycerin. If you can find some normal segment, then probably you can avoid even balloon dilatation, because obviously many times the thrombus gets squeezed and the slow flows are more common if you do more and more balloon dilatations.
All right. Thank you indeed. Anybody has any more questions or comments? Our three speakers for today. Do you have any comments? Otherwise, we'll go to the last case.
This patient did not create trouble, Anuj, no? The distal PLV being occluded also, no pain, nothing.
No
person
pain.
was creating some
totally
confusion, but it may not be because no pain here. Right?
No pain, sir. That's why we have not changed it also.
Okay. That is a variable presentation. But even in the first patient also, it may not be totally because of that vessel only, because it was persisting for three days, and then later also he had some pain. It could be various different reasons also for it. But obviously, when you have the blocked artery, you would first consider that. But here, this patient fortunately is better.
My question is,
pain for a longer time, like pain happening on day 2 and day 3 after an occluded vessel, is probably not an ischemic pain.
Yes, true.
I think
my question is,
yeah, go ahead.
So my question is, means how will we decide which thrombus we should chase? Usually what we follow, particularly in anterior wall MI, if there is a distal thrombus in distal LAD, we usually don't chase it. So the same thing can we apply on the same, like we should not chase the PLV in the inferior wall MI, because we have already opened a big channel, and the channel will actually over the period of time will help to thrombolize that particular thrombus which is already present inside the PLV.
So if you're doing early enough and you are in a good time, like inside 2 hours after onset of chest pain, I think you should try and clean up everything. It would definitely help, because artery opens on its own after, we don't know, 7 days or 10 days. That may not be so important as artery opening up in first hour or first 2 hours.
And how far distally from the stent you are placing also matters. Suppose the occluded vessel is just distal to your stent, you are very uncomfortable leaving it. You have to open it well. There should be good distal runoff at least in one of the bigger vessels for the stent to remain patent. Otherwise, just immediately after the stent, if it is occluded vessel, then you can't leave it because it tends to get occluded.
Or bring the stent to cover that site of occlusion.
Yeah.
Put a slightly longer stent and you cover more. Okay, Dr. Omkar, should we move to next presentation? Thank you, Dr. Anush. It created a lot of discussion. We had pretty similar
We'll
looking
move to
two
third
cases.
presentation.
Young patient, total
Yeah.
occlusion of the right coronary, occlusion of the PLV2. I think that was quite simple.
That's what it is.
Yes, and then both these operators have used different tricks. All the tricks rather, to get a flow open and flowing artery. So we move to the last case.
Dr. Parag
Rahatikar, yes.
Dr. Parag, you need to unmute yourself first. And
yes, is it audible now?
yes.
Yes. Okay. So good evening, everyone, respected seniors and my dear colleagues. It's a pleasure and a privilege to speak in front of respected Hiramat sir and Srinivas Kumar sir. And it's a great honor to learn from them. And start screen sharing. Is it visible now?
Yes, you need to just make a full mode.
Yeah. Okay. Yes. So my case is a interesting case of post-COVID myocarditis. Myself, Dr. Parag Rahatikar, cardiologist in Nagpur. The case history: patient is a 56 years old female, not having any comorbidities, and she was tested COVID positive in February with a CT score of 7/25 and was treated with a remdesivir LMWH on an ambulatory daycare treatment basis. Post-COVID treated, she was nearly asymptomatic for a month. And after 1 month of being near normal and doing her regular day-to-day activities and being asymptomatic, she now started having fever, which was a high-grade and continuous type of fever. Also, there were no localizing signs. That is, she had no cough, headache, any burning micturition, or she also did not have any breathlessness, chest pain, syncope. And her fever was continuous, only relieved for a while with paracetamol, but again recurring. And on general examination, she had a pulse rate of about 100 and blood pressure of about 106/70 millimeters of mercury. Her systemic examination was unremarkable. So her labs were repeated. Labs were done on day 2 of fever, and it showed a slight anemia with a neutrophilic leukocytosis, about 93% neutrophils on a differential leukocyte count. Her platelets were within normal limit. Her kidney function test, liver function test were also normal. Her urine routine examination, she did not show any abnormality or no pus cells were there. This was her chest X-ray, which we see that the left side of the left zone appears near normal, and the right side in the mid and lower zone appears haziness. So suspected some lower respiratory tract infection in this case, consolidation-like picture. And also, as it was in the time of COVID peak, so her inflammatory markers or suspicion of some repeat COVID infection was also done. But her surprisingly inflammatory markers on the day 2 of illness were within normal limit. That is, CRP, ferritin, LDH were all within normal. Also, the D-dimer was not raised. And her COVID RT-PCR was done, but it came out to be negative. Also, in view of continuous fever ongoing, the blood culture sensitivity was done, but it also did not show any growth. Also, to rule out any other focus, any abscess underlying or not. So a USG abdomen was done, but it did not show any abnormality. And surprisingly, the CT thorax was also done, but it did not show any specific focus, consolidation or patch. And the CT score at that time, that is 1 month post-COVID, was about 0. So with this initial workup, she was started with levofloxacin and augmentin in suspected lower respiratory tract infection with antipyretics and supportive care. But despite all these measures, her fever persisted and even was on day 4. Patient started complaining of breathlessness and on even less than ordinary activity, that is NYHEC grade 2 to progressing to grade 3 now. And her saturation at room air was 95%. The tachycardia was there, and blood pressure was borderline about 94/70 millimeters of mercury. So her inflammatory parameters were repeated just a day after, and it had suddenly jumped up. That is, interleukin 6 had jumped to about 576. CRP has also increased now. Ferritin, LDH, all had increased. To rule out any septic focus, we had done a procalcitonin, but it was normal. That is, no septic focus or source of sepsis was found out. And in view of breathlessness, her cardiac markers was also sent, which were also raised. That is, troponin T was about 92, and NT-proBNP was also in the range of 5,712. This was her ECG, where if we see the ECG, it was a sinus rhythm with narrow QRS, normal P wave, and if we see the STT changes, then in about inferior leads 2-3 AVF, there was slight 1 mm ST depressions were there, but no frank ST elevation. Also in the chest precordial leads, we cannot see any poor RV progression or any STT changes in the precordial leads. And also the echo was done. So echo showed slight LV dysfunction was there, more in the, say for example, anterior and anteroseptal segments, we may say LV dysfunction more of, but there was no correlation with ECG with this respect. So diagnosis was kept as a case of acute febrile illness, most likely a viral infection or maybe a post-inflammatory illness with LV dysfunction and left ventricular failure, maybe a myocarditis, more likely as compared to ischemic in view of the type of hypokinesia and non-specific STT changes in the ECG. And she was also, at the time of admission, she then finally went into cardiogenic shock. And she was started on management with diuretics, antiplatelets and anticoagulants, both were started, and put on inotropes with high dose antibiotics. And also in view of this raised inflammatory markers and this procalcitonin being normal, she was started on this steroids with a methylprednisolone pulse therapy. And she responded very well to this treatment of steroids with heart failure management. And clinically, her symptoms of breathlessness also started showing improving trend. And the blood parameters, which were repeated a day later, though the neutrophilic leukocytosis was persisting, but the peripheral smear did not show any toxic granules or any markers of sepsis. Her PCT remained normal. Her LDH, ferritin, and CRP levels started showing a declining trend. But the NT-proBNP, as it was a peak state, so it was raised to more than 35,000. Her liver function test, KFT, and all other vital organs did not show any abnormality. That is, there was no evidence of any multi-organ dysfunction at this stage. Her hospital stay of about 5 days was uneventful, and a follow-up echo was done at day 5, which showed a dramatic improvement in the LV function also, with a near normal or say EF of about 50%. And she was then later on discharged on antiplatelets, oral and oral anticoagulants. A tapering dose of steroids were given with heart failure treatment, and a follow-up blood parameters were repeated again after 2 weeks, which were within normal limit. Also, the CBC had normalized with the leukocytes within normal limit, and a follow-up echo was also showing a near normal LV function at about 2 months of follow-up visit. So when we were tackling the case, we had some points to discuss or what lessons we learned from the case. So one was that the presentation of myocarditis and the etiology in the current pandemic scenario, that is whether it is a post-COVID or whether it is a post-viral myocarditis or any cytokine storm related or inflammatory state related myocarditis. Then what further tests were needed, which we did not do for labeling it as myocarditis. Like cardiac MRI was planned in that setting, but as the COVID pandemic was in its peak state, so the patient and relatives were not reluctant to go to a imaging center for cardiac MRI. And the patient was also on inotropes. So first plan was to at least settle down the patient. Also angiography to rule out any acute coronary syndrome was also not done in that setting, immediate setting, as the patient was having a high grade fever with a raised inflammatory markers. So these were the 2 tests which we felt that were necessary also and were not possible in that time. Then what are the other clinical manifestations of COVID myocarditis? Like we should be careful for any arrhythmias like heart blocks or any new VT or any STT changes to occur. Even as we have seen, coronary thrombus and MI is also common in COVID scenario. So we should also think for these clinical manifestations during the admission setting. But luckily, the patient, apart from this breathlessness and heart failure symptoms, she did not have any arrhythmias or any coronary syndrome like manifestations. Her ECG daily repeated, but not showing any new dynamic STT changes. And the treatment or protocol for managing such patients, when we see various studies, it is a bit different. Like many patients prefer or many doctors prefer using a tocilizumab or other drugs to tackle this cytokine storm. But luckily, our patient responded well to IV methylprednisolone steroid therapy. So you have a few learning points or few data from the studies which we see. So the pathophysiology for this myocarditis, it is basically a combination of a direct cell injury and a T lymphocyte mediated cytotoxicity augmented by this cytokine storm syndrome. And the main marker or mediator of this cytokine storm is found out to be interleukin 6, which where it orchestrates the inflammatory responses from the immune cells, including the T lymphocytes. And these are all the this COVID-related pathways or ways by which it can cause myocardial injury. Like for example, by either direct damage or a systemic inflammation, or by causing interstitial fibrosis, or a interferon-mediated immune response, or a helper T-cell cytokine response, or due to cyto or hypoxia-mediated myocardial injury, or mostly a coronary plaque destabilization causing a thrombus and myocardial injury. And this is the protocol which we can follow in this COVID patient, COVID patient suspected with myocarditis. Like on the basis of clinical history, whether patient is having breathlessness, chest tightness, any arrhythmias, or frank cardiogenic shock, or a new onset right heart failure. These are the manifestations which are commonly found in this COVID-related myocarditis. And if any one of these are present, then we should get basic tests done like ECG, enzymes, where both troponins as well as NT-proBNP play a very important role in our diagnosis. Also, simultaneous inflammatory marker assessment is important, like a CRP, ESR, and a bedside echocardiogram to look for the type of hypokinesia, whether it is a global hypokinesia, a regional hypokinesia. Also, in echo, we can pick up some of clots, like for example, a large clot in the right atrium, right ventricle, that can also be picked up on this echo. Then we should, the differential diagnosis which we also had in our case was like whether we are dealing with any acute coronary syndrome or not, or whether this is a frank myocarditis or a sepsis-related cardiomyopathy, or maybe also a Takotsubo-like stress cardiomyopathy, because the patient was also female, about 56-year-old. So also, and it was a reversible cardiomyopathy. So whether it can be a stress-induced cardiomyopathy or not, so that was also a differential. But as the troponins were raised in this case, and also the echo was not showing any transient apical ballooning like picture. That's why our more diagnosis was more favoring the case of a myocarditis in this case. And like for example, if the diagnosis is unclear, we can look for further investigations like a cardiac MRI or a CT angiography or an invasive angiography or a contrast enhanced CT. And if last resort in such patients is a endomyocardial biopsy, like if patient is not improving, is in persistent shock, and the hemodynamics are not that much improving, then to rule out or to rule in some diagnosis, we can plan an endomyocardial biopsy in such cases. So this should be the investigation protocol which we can follow in a case of suspected myocarditis. And the management strategy in such cases, if we see, so we should avoid treatment of sinus tachycardia with a negative inotropic agents like a metoprolol or diltiazem or verapamil, as the cardiac output may be dependent on the tachycardia itself. Also, we should avoid use of NSAIDs to cause further harm, which can cause further harm. Then the main thing is the heart failure management. So treatment should be according to the cardiogenic shock protocol itself, with triggering the use of support devices like ECMO, VAD or IBP if required. And the cytokine storm, which is main seen in such scenario, should be managed with either IV tocilizumab, or we can also give steroids or IVIG in such cases. IVIG has more of been found a role in a pediatric population who are having myocarditis or systemic inflammatory response syndrome. But steroids are often beneficial and are found out to have a good role if they are started early in the course, especially. And lastly, we should also look for any evidence of arrhythmias, bradyarrhythmias or tachycardias, and avoid use of QT prolonging agents like macrolide antibiotics or antimalarials in such a setting. I thank you all for the patient hearing, and thank you again.
Very well done, Dr. Parag. It was a very express presentation. You covered so much.
Thank you.
Probably first time when a balloon was not going in the coronary. Oh. So
Yes, sir.
It is interesting, really, how you handle. I mean, everybody has gone through these phases. The way we address these COVID positive myocarditis. 1.5 years back, 6 months back, 2 months back, and now I think there has been a clear change. Dr. Srinivas, you want to suggest this patient was given low molecular weight heparin
Yes, sir. Low molecular weight was in therapeutic dose was given, sir, as the troponins and this were also raised.
Yes.
As angiography was also not done, sir, in view of high-grade fever and raised inflammatory markers. We avoided initial angiogram in that setting. But prophylactically, loading dose of antiplatelets, statins, and anticoagulants at full dose were given, sir, to the patient.
So, like an ACS,
Yes.
angiogram.
Yes.
No, but angiogram, unless even the recommendation wise, unless there is a specific suspicion of regional wall motion abnormality or a particular territory change in COVID positive patients to avoid infection exposure to others, we are avoiding. That is one. Number two, if patient is too sick, once he goes into cardiogenic shock, many other times critical care people force us to take the patients to cath lab and revascularize, unless there is some definite evidence of acute MI, STD elevation, things like that. What data showed out and came in the recommendations also later with ACC and SKY. This desperate measures that doesn't work. So this is futile attempts, they called it. And you're not supposed to take these COVID positive patients who are already into sepsis type situations, multi-organ failure and cardiogenic shock. There's no point wheeling them to cath lab unless they're exposing everybody. And that is a situation where you again should avoid angiogram. So unless you have a specific evidence to say that it is a particular arterial block or something like that in the COVID positive patients, and we can avoid always exposure to cath lab and the staff. That's important. And what you showed, regular protocol worked well. And of late, I think one thing which started in second wave, sir, of late we started using this cocktail regime, the Regeneron medicine, which is supposed to be working well when the patient especially presents very early. First 2 to 3 days, once you give it, definitely less complications we have seen. And
what is cocktail regime?
Yeah, cocktail regime, or Trump regime, whatever people call it. So that actually works well if the patient. Sir?
Cocktail regime includes what all?
Cocktail regime, it includes two types of anti-immunoglobulin type of drugs. The peculiar names are there for two of it. Ending with globulin, and those two mix it together in 5 ml and given as infusion, and it actually comes in higher doses, but to save cost sometimes we are sharing between patients also, so that way the cost instead of being 1.5 lakhs, it could be finished in 80,000 also. So but that worked well. We have seen quite a significant number of patients initially when they're given. They're less complication prone and less problems of getting into low saturations and myocarditis. And here I think, I don't think that even Takasubo type thing as exclusion, you have mentioned yourself, no apical ballooning, other things. But generally when there's so much of systemic inflammation markers positive, I don't think we should consider anything else, especially in these tough COVID times. Even if the COVID test comes negative also, still we would feel it could be still COVID, post-COVID manifestations, things like that. I think fortunately we managed it well and improved. We have seen quite a lot of patients presenting, but when they come very late where the BP is already low and multi-organ failure, they never recovered. But if they come early, then probably these drugs could benefit, and steroid play a significant role along with low molecular weight heparins. One thing which has proven mortality benefit definitely, as you understand, is one is anticoagulants, low molecular weight heparin, followed by NOACs. And the other thing which is definitely proven is steroids. I think we have strong data. I think third one, which I feel now, is it's cocktail regimes, which works if given very early. And rather than like other drugs which were given, which are not available, and all that is not recommended now. But these three drugs, I think, will work very well.
How long do you think in this kind of case, Dr. Srinivas, we should continue anticoagulants?
Yeah, that is generally if a patient is quite stable without evidence of any thromboembolic event anywhere, probably we were giving for 6 weeks, and then depending upon if you want to be absolutely sure, we just check once these parameters like LDH and CRP, ESR. If still are elevated, we are continuing for 3 months. But if all of them came down, we were stopping after 6 weeks. But this doesn't apply if patient has already developed a thromboembolic complication. Then you follow the thromboembolic protocols, like 6 months you at least give, and then reassess what is recommended even for DVTs, things like that, and then watch it. What I'm talking is Only COVID without obvious evidence of thromboembolism, we generally do it till 6 weeks. If still assess the activity, then still it is higher markers, then you continue up to 3 months. That's what we are doing regularly.
The other issue I wanted to ask is, this was a clear myocarditis which improved, but suppose there is no improvement, the indication for steroids gets stronger?
Because we keep trying, no, sir, but in generally, again, if inflammatory markers are high, I feel steroids will work. If all the markers are not high, only LV dysfunction you want to pump in steroids, it may not work. So I think everything together we have to assess, and in such sort of high inflammatory conditions, I think steroids do work. Methylprednisolone also, I think you gave a bolus. That also people have seen it works.
Other comments from anybody else?
Yes. So one question regarding this heart failure management. So this, as the patient has now heart failure with near normal ejection fraction. So this, whether we one is two, as per data, we should continue this ARNIC with beta blockers at least say lifelong to the patient.
Other thing you mentioned is, don't give beta blocker. A blanket statement you made, it may decrease the cardiac output, you said. It's always relative, you see. It's suppose sometimes the heart rate is too fast, like more than 130, 140, that itself could be deterrent again for the cardiac output also. So we see the clinical scenario and then decide about giving beta blockers. And touch of it always helps, I feel, because beta blockers are drugs which are proven beyond doubt that they help in heart failure patients. Unless you are not able to give beta blocker because low blood pressure, then you should always try to give some small dose of beta blockers. If a patient has associated bronchospasm and very high stuff like that, you might avoid metoprolol, which we generally use. You might take the help of maybe carvedilol, or we sometimes tend to use nebivolol also, which is less bronchospasm prone, we feel. But always try to give, sir?
Ivabradine also.
Ivabradine. Then after giving beta blocker also, if still heart rates are high, recommended is ivabradine. But in some conditions, as we said, hypotension is happening where you cannot give beta blocker. We still tried ivabradine also in smaller doses just to have some effect. But beta blockers, always we try to give it unless you can give it. Okay. And other thing we mentioned is how long we should give these molecules. That again we decide depending. This is an acute event, you see. When COVID happened, the patient worsened. Once it recovers back, probably you need not follow all the guidelines like cardiomyopathy, which this is some, I think, acute happened. LV totally recovers, then gradually you might tend to withdraw and see, but be slower and at least continue for 6 months to 1 year, and then you can decrease the dose. But if patient has a associated hypertension or something where there's indication to continue, obviously you will continue. Yes. And previously people were worried to use SGLT2 blockers in COVID patients, but now that is also proven wrong and they're found to be quite safe even in COVID patients. Only thing is you should not use it acutely when the patient is on catheter and things like that, because sometimes urinary tract infections, other things are described with it. But once the patient is off, then you can tend to use even SGLT2 blockers even in these patients.
These kind of cases, like patient got better over a length of time and went home in a good shape. Should we do angiogram, or Parag, you did angio?
No.
No, sir, not it.
So should we do angio or at least a CT angio in these cases? I mean, tachycardia, of course, was quite a bit, so we're getting a good picture on CT angio must be very difficult, but a conventional angiogram.
Conventional angiogram in COVID positive patient, unless there is definite evidence, it's not indicated, sir. But after patient recovering, you are saying after 6 months or so, just want to rule out, then probably if there is any suspicion or ongoing LV dysfunction persistence like that, you could still do it. Or if patient has risk factors and elderly, you could still consider. But younger patients with definite COVID history, I don't think it is indicated.
Okay. Any other comments?
I think we had good discussion, sir. I think it's 9:30, 9:24. I think
Yes.
two typical no thrombosis type suitable cases Omkar got today, and two had the strange thing is two had similar results, and two different protocols done. Both patients did well. That's the beauty of medicine.
So that's incidental, sir. Nothing we have particularly.
Then it's okay. But it was we had good discussion, and finally patients are saved. That's what gives maximum happiness for the clinicians.
Yeah, actually, so many times, like go on round next morning, and there is so much discussion on a given case. What to use, especially if the patient is hypotension and not responding very well to the existing therapy. That is where all this discussion takes place. And Dr. Srinivas was very keen on using steroids to understand it in difficult cases.
In this sort of thing, COVID inflammatory markers and all that, sir, definitely I think people are using. But patient presentation early is, I think, even there it matters. Patient comes very late with all the worsening situations, SARS state, systemic inflammation, all the organs down. Whatever you do, they are not recovered. Once they go into dependence on oxygen, then next on to ventilator, then finish. That's the last stage generally in COVID. Once they go into ventilator, they're difficult. Nowadays, we are seeing a lot of post-COVID recovered myocarditis patients also, sir. LV dysfunction and then some sort of pulmonary problems. I think such sort of cases also now in the risk factors profile in the list, hypertension, diabetes, how we used to write, now you should write COVID positive, negative. So that could be also having a lot of implications on follow-up. COVID cardiology is another specialty which should come up in future. So there's all things, but a lot of varied presentations are also seen. And luckily, all of them were in small percentage of patients, but because whole number of population who got infected or more, that's how we used to do see some cases, especially for higher centers, the patient do present. I think Omkar is seeing time, we'll stop. And before we close, sir, I would just request everybody to join for TCT India meeting tomorrow. Very happy to say that we had 5,000 plus registrations and 1,000 registrations even for live presentation in the PVR cinemas and other hubs. Unfortunately, Pune government didn't allow, we couldn't have it. But many other places, wherever it is open, but for Kerala and Maharashtra, Mumbai, Pune and Trivandrum, these three centers, we couldn't do it. In Hyderabad, because of increased response, we have to book a second center also. So that is a quite good encouraging response for all the countries. All the companies did quite a lot of good work, and Emcure also did it. Thank you very much, and request all to join for tomorrow's session. It starts at 3 p.m. in the afternoon, and tomorrow is the India valve session, and day after tomorrow and the next day is all full coronaries and other sessions. Dr. Hiramat sir is performing a live case day after tomorrow along with others. It is at I think it is in the afternoon 4 o'clock. So request
all our good wishes from
thank you, sir.
The entire group who has been together for every meeting which Dr. Omkar Swami has organized.
Yeah. Sir is also always supportive for our meetings also, right from start. This is 12th year. Every year, I think we never missed sir. And it's always a great help. That's why when you're saying no, sir, 2 hours also, I immediately say yes, because whatever you say is like a rule for me. So it is no question of saying no, unless I am informed very late. If already some issue is there, otherwise, if you inform prior, whatever you say, it is done, sir. There is nothing. And we always ask for good things only. There is nothing that we are especially doing separately. But I have listed this time as knowledge partners, sir. Yes. I have listed no thrombosis as well as the acute MI workshops in that specifically. Because what does it mean is various meetings which we are doing, if anything is good, we are picking up and putting in the TCT forums also. So that way, the quality also improves because of all good meetings coming up with small, good cases. And a lot of youngsters are presenting very interesting cases there.
Yes.
A lot of pressure, sir.
I understand that there is a lot of pressure in choosing the cases.
Yes, sir. Yes.
So many cases are coming.
Yeah.
I'm not involved in choosing the cases.
No,
I, in fact, don't know who chooses these cases, but I guess somebody is doing a very good background.
Omkar, I think back behind works very well for this to select good cases.
Yeah.
Thank you.
So very good effort on part of Emcure
Yeah.
on bringing us together again and again. And having been in this field for over 30 years, I still am learning from every meeting that is going on. So, Dr. Omkar, really we are thankful, and we get company of Dr. Srinivas Kumar and Dr. Putti on this forum, and that's also a big excitement for us.
Yeah, we should say that, sir. Thank you.
Thank you, sir. Thank you very much, sir. We are catching up on 12th of August at 8 p.m. with 3 interesting cases. So we'll take a break for 15 days and catch again for 3 new cases. With that note, we will stop here, sir.
Right.